There's a prescription I think almost every woman should eventually be on, but most of them don't know that it could improve their future. Things change as we age, but there's no reason to suffer unnecessarily, especially when there are cheap and easy solutions that can help you live more as you get older rather than less. If you want to improve your overall resilience while lowering your risk for urinary tract infections, urinary incontinence, vaginal dryness, pain with sex, and more, I think it's worth your time to learn about vaginal estrogen and eliminate these problems before they even start. You're listening to the Health Courage Collective podcast, episode 213. Every woman should be on this prescription. Welcome to the Health Courage Collective podcast, the show for women who are too busy to slog through hours of generalized, inapplicable, and often contradictory health information, but too smart to ignore that a few minutes of focused attention now can prevent years of suffering in the future. I'm your host, Christina Hackett, a pharmacist who doesn't want you to live on prescriptions, a certified coach specifically trained to maximize your potential, and a compulsive learner obsessed with preventative, cutting-edge, holistic, and integrative medicine. I'm on a mission to increase your physical and mental resilience so you can fearlessly look forward to your next 40-plus limitless years. Your time is now. Let's go. Hi, my friend, and welcome to the episode. I hope everything is going well for you. How is your paranoia? Have you been able to use a little inverse paranoia this past week? What differences have you noticed when you walk around believing that everything is orchestrated for your good? As a pharmacist whose income depends on people filling lots of prescriptions, I'm pretty adamant that I would love for the vast majority of people to not take any medications, as a general rule, with some exceptions. This is my number one exception. Well, there are life-threatening situations and desperate emergencies and major conditions. So maybe that's not a great way to put it, but I do think that almost all women should be on this medication eventually. Here's why. What if we lived in a world where half of the population suddenly had a dramatic physiologic change that resulted in a vastly increased risk of urinary tract infections, urinary incontinence, bacterial infections, constant discomfort, and pain with sex? And even though there's a super easy and pretty cheap prevention for all of these things, we tell them to all just suck it up and deal with the consequences of each of these 5+ conditions separately. It is crazy to me that this is the world we live in, and I'm pretty sure if it were the other half of the population that were all suddenly forced to deal with the major daily life consequences of this change to their physiology, it wouldn't be so ignored, which is pretty awful. Urinary tract infections, or UTIs, provide you with burning pain that is particularly disruptive to work productivity and sleep, and in older people often presents with delirium, confusion, lethargy, loss of appetite, or life-threatening falls. They can even progress to sepsis. Something else that is a very big deal to me is that every course of antibiotics you have to take whomps your microbiome and makes you way less resilient, in a big way. Being able to avoid a course of antibiotics for any reason is a really big win in my book. And I don't have to tell you that urinary incontinence pretty much changes your life. Having to wear bulky pads all the time, not knowing what might happen or when, or feeling like you can never be out of eyesight of a restroom can change what experiences you say yes to, your perception of yourself, and your sense of independence and personal power. Vaginal dryness can cause general discomfort and pain, like all the time, which affects every aspect of your life, and it alters your vaginal pH and vaginal microbiome, increasing your risk for bacterial vaginosis and other problems. Again, decreased resilience and increased risk for having to take antibiotics. It can also lead to dyspareunia, which is pain before, during, or after sexual activity. Your life satisfaction is affected when your personal relationships are affected. And your relationship is definitely affected if one of your ways to connect with your partner now causes sharp, throbbing, burning, or aching pain. Even if it's not outright painful, pleasure and often desire is usually vastly decreased when there's vaginal atrophy because there is a lot less blood flow to the area. Again, not something I think men would just passively accept as being off the table for them once they reach a certain age, especially when it doesn't have to be. We talked a little more about this in episode 166 with Lana Kerr if you want to hear more about that. There aren't great exact and specific numbers, but your risk of a UTI is somewhere around 20% as a premenopausal woman and somewhere around 55% after menopause. Again, I'm not sure what exactly that means, like over the course of a year or what. Don't know. But the risk more than doubles, that we know. There aren't great numbers for this either, but 70 to 30% of premenopausal women experience urinary incontinence. And according to what I found, 83% of women over age 70 have urinary incontinence. That's pretty shocking. There are other contributing factors to that, but this is one piece to that puzzle. I know an awesome pelvic floor physical therapist named Christina, who I might ask to come on the show if you feel like it would benefit you to hear from her, which I think it would. More fuzzy numbers. Risk of bacterial vaginosis is around 30% premenopause and 40 to 57% postmenopause. Vaginal dryness is a problem for about 17% of women premenopause and at least 56% of women postmenopause. And dyspareunia is about 10% premenopause and 50 to 84% postmenopause. Most women don't try to get help for these issues from their medical provider, and many of the ones who do are dismissed. So they go about their lives silently changing the physical activities they're willing to participate in and the adventures they're willing to take. Feeling guilty about their participation or lack thereof in their romantic relationship, or disappointed in their experiences. And taking antibiotics as often as the need arises, affecting all areas of their health, including their mental and metabolic health, but especially their immune system, at a time when their immune resilience is already declining. Why is this our reality? It's infuriating. You probably have some good theories. One could be that since it's common, we just accept it as normal. It's just part of aging. But it doesn't have to be. Another could be that the medical establishment just knows more about male genitals than female ones. That is a fact. They are less complicated. Another theory could be that women are better at suffering in silence than men, or that historically women were labeled hysterical or whiny if they complained about anything. But I think the biggest reason is that the cheap, easy, and effective solution to all of this that I think almost every woman should eventually use is so embroiled in misinformed controversy and fear that medical providers are so unnecessarily and illogically terrified to the point that they're not willing to see the clear evidence right in front of them that they have the opportunity to help women live better lives. Higher functioning midlife and mature women provide a gymongous benefit to society at large. Providing a benefit to women who've had the time to accumulate wisdom benefits everyone. The world is better for kids, elderly people, bookworms, Kanye West fans, Republicans, Democrats, gamers, endangered animals, you name it. Part of a longer discussion, but all of the increased risks that we're talking about today can be reduced by the use of vaginal estrogen. While medical providers have been seriously misinformed and fear-mongered into believing that there are huge risks to prescribing estrogen for women, they almost never think to wonder what the risks of not prescribing it to her are. Also part of a longer discussion we won't get into today, but I think it's a good question to consider for yourself. Are you concerned about the risks of taking hormone replacement therapy? Good. That's good judgment. It's good to be prudent and skeptical. But have you considered the risks of not taking it? Because there are a lot of them. A lot. But for today, we're not talking about hormone replacement therapy, as much as I enjoy doing that. Not really. That's more systemic replacement of hormones. When you use small doses of estrogen vaginally, the effect stays localized to the genitourinary area. So you're not getting more estrogen throughout your whole body. Your whole genitourinary system, including your urethra and bladder, are very hormone sensitive. Locally applied vaginal estrogen helps keep your vaginal pH where it should be, decreasing your risk for bacterial vaginosis and other infections. It cuts your risk for urinary tract infections in half. Vaginal estrogen increases elasticity and strength of the vaginal and urinary tract tissues, improving bladder control and regulating bladder sensitivity, reducing urge incontinence. It improves moisturization, blood flow, and thickness of the vagina, reducing the chances of pain with intercourse and increasing pleasure and desire. According to an awesome physician named Rachel Rubin, less than 6% of internal medicine, OBGYN, or family practice doctors get 1 hour of menopause education in their medical training. These are the very doctors women rely on for care, and 94% of them got no training on how to do so. No wonder they're reluctant to help. They haven't been taught how. All they've been taught is that hormones are dangerous, which was all based on an idiotic interpretation of one study. The medical community should be embarrassed and ashamed that they're so inept at caring for such a huge portion of the population. Dr. Rachel Rubin once said, "Women's health, menopause in particular, is important to nobody. When it's nobody's problem, nobody takes ownership over it." End quote. It's true that family medicine doctors, internal medicine doctors, even OBGYNs and endocrinologists aren't trained and don't consider themselves the person to treat perimenopause and menopausal symptoms. So who does? Almost nobody. It's crazy. I learned from Dr. Rubin that this problem we're talking about today used to be called the senile vagina. What the heck? I'm not even going to say anything about that. The name was changed to vulvovaginal atrophy or atrophic vaginitis. Then the name was changed in 2014 to genitourinary syndrome of menopause, which is better because it's not just a problem of vaginal dryness that can be corrected with a lubricant. The bladder, urethra, vagina, and everything in that area is screaming out for hormones. Hormones reduce urinary urgency, urinary frequency, urinary leakage, urinary tract infections, the vaginal pH. They improve vaginal moisture, blood flow, pleasure, the microbiome, and ability to resist infections. Dr. Rubin published a study in the Journal of Urology Practice in 2024 that showed that if Medicare patients used vaginal estrogen, we would save Medicare $6 to $22 billion a year. That's billion with a B, $22 billion. And she says that she thinks that's a pretty conservative estimate. Hello. Low-dose local vaginal estrogen, or DHEA, reduces your risk of urinary tract infections by more than half, plus all of the other benefits of improved blood flow and reduced dryness, leading to more general comfort and better sexual function. Improved microbiome and pH, leading to reduced risk of infection and reduced urinary urgency, frequency, and leakage. The cost benefits are staggering, but I think the quality of life benefits are just as big. Feeling capable of doing whatever physical activities tickle your fancy, not having to feel like you're wearing a diaper, not having to always know where the nearest bathroom is, being able to choose to be intimate with your partner, and not having to take antibiotics. Not to mention that when you're much older, the consequences of a UTI are potentially deadly, like falls, delirium, and sepsis. One of the reasons prescribers are reluctant to put women on vaginal estrogen is because the official medication monographs contain what are called black box warnings about seriously scary side effects. They are definitely proven not to be true, but even though they don't belong there, they're still there. It's a whole politics of the FDA rabbit hole. But basically, the medications contain the scariest warning possible to providers that they cause blood clots, breast cancer, endometrial cancer, cardiovascular disease, dementia, heart attacks, strokes, and pulmonary embolisms. Even though they don't. It's been proven that they don't. It's not even a question anymore, but the warning is sticking around like flip-flops on a movie theater floor. To be clear, you can get systemic or full-body dosing of hormones placed vaginally. But in the case of vaginal estrogen, the dose is so tiny that it doesn't go anywhere else. If you've heard of the dangers of taking systemic steroids like prednisone or methylprednisolone or solumedrol or dexamethasone, there are a ton of side effects and dangers, and you really have to be careful. I like how one doctor compared the risk profile of vaginal estrogen, kind of like the risk between intravenous solumedrol and over-the-counter hydrocortisone cream. Very similar, but a much smaller dose, locally applied, and vastly different risks and effects. So if you were to take systemic estrogen for hormone replacement purposes, you'd probably get a dose of estradiol somewhere in the 1 to 2 milligram range. There are a ton of factors that should go into that decision, but that's just what would be considered, quote, normal, 1 to 2 milligrams. Vaginal estrogen tablets are 10 micrograms, so 0.01 milligrams, or vaginal estrogen cream is 0.1 milligrams per gram, or 100 micrograms, or 0.1 milligrams. So we're talking 1/20th to 1/200th of a normal systemic dose, applied locally. Those are the two main vaginal estrogen products I think about. Vagifem tablets, which are 10 micrograms of estradiol and come already in a vaginal applicator ready to be inserted. And estrase cream, which is 100 micrograms per gram of cream and comes with a vaginal applicator, and you have to measure a certain amount of cream into the applicator and insert that. They're both available generically with a prescription. In case you're interested, which you probably aren't, Novo Nordisk made the original brand name Vagifem tablets, which were 25 micrograms and were sold brand name only, as all new drugs are in the US at first, starting in 1999. They enjoyed their 10 years of insanely high brand name drug prices. Then, magically, 10 years later, in November of 2009, Novo Nordisk got a brand new patent for 10 microgram tablets. The story repeated everywhere is that they care about women and they wanted to align with medical recommendations to use the lowest effective dose. So new brand name 10 microgram tablets started to be sold, and Novo Nordisk discontinued Vagifem 25 microgram July 30th, 2010. So it never had an opportunity to get to a point where a generic could be made. You know, because Big Pharma cares about women. Anyway, it's been long enough now that there are generic 10 microgram Vagifem tablets available. The Vagifem dose is to insert one 10 microgram tablet vaginally twice a week. The generic ones are around $50 for 8 tablets. Brand name is like $200 for 8. And some sort of generic brand called Uvifem is $160 for 8. Most likely, your prescription insurance would help you pay for the generic version, so you'd be just paying whatever your copay is. The estrase cream dose is around 2 grams of cream inserted vaginally every night at bedtime for 2 weeks, and then 1 to 2 grams of cream twice a week after that. Depending on how much you used, your first tube would last about 2 months, and the next tubes would last longer than that. The generic is about $40-ish for a tube that will last for 2 months or more. The brand name is $360 a tube. Normally, I'd say there's no reason not to use generic, but there have historically been many problems with prescription drugs manufactured in India. I hope it's getting better, but I'm not totally sure that it is. The Glenmark generic version of Vagifem is likely made in India. The Uvifem might be, and the Teva could be, but might not be, as Teva makes drugs in Israel, Europe, Australia, and South America. The generic for estrase creams seem to be less likely to be made in India. Predagus brand is made in Israel. Prasco says they manufacture in Ohio. And Alvagen is in Romania, Korea, and Taiwan. So just a little food for thought there. There also exists Premarin vaginal cream made of horse estrogen, and it's about $250 a tube. I would say never use that when you have bioidentical human estrogen options, because that's just stupid. There is also a prescription called Estring, which is a vaginal ring you insert and leave it there for 90 days. That's also a good option. It contains 2 milligrams of bioidentical estradiol that releases at an approximate rate of 7.5 micrograms per day for 90 days. It's a ring that you insert vaginally and just stays there. You don't feel it. You just have to remember to change it every 90 days. The only real downside to Estring is that it's still brand name only, so it's about $250 for one ring. But there's a good chance your insurance might help pay for part of it. And to make things more confusing, there's a different vaginal ring called FemRing that is not bioidentical estradiol, and it is for whole body menopause symptoms, not just genitourinary symptoms. There's also NuvaRing, which is totally different, except for that it's also an estrogen-containing hormonal vaginal ring. But NuvaRing is for birth control. FemRing and Estring are for menopause, but only Estring is for vaginal genitourinary help. There's something else interesting, which is relatively new, called Intrarosa. It's a DHEA vaginal insert, kind of like a suppository to be used vaginally. It has DHEA in it. Maybe we can talk more about DHEA in the future, but it's a steroid hormone that is often, but not always, included in bioidentical hormone replacement therapy. Send me a message at healthcouragecollective@gmail.com if you want to know more about the hormone cascade or DHEA. DHEA is upstream in the cascade, so it's the precursor to testosterone and estrogen. So when you insert DHEA vaginally, it is converted to both testosterone and potentially multiple types of estrogen, which is kind of cool. It's a prescription-only product approved for painful intercourse due to vaginal dryness from menopause. Dr. Rachel Rubin published a study just a couple months ago in March of 2025 in a journal called Menopause, showing that the DHEA insert, Intrarosa, reduces the risk of UTIs by more than half, same as estrogen does. But your vagina, vulvar vestibule, clitoris, and bladder all have androgen receptors in addition to estrogen receptors. Androgens are testosterone-related hormones. So while estrogen is good for the genitourinary system of women, so is a little bit of testosterone, which is why the precursor to both of them, DHEA, seems to be a great option. While both Vagifem and Estrace are dosed twice a week, the DHEA insert, Intrarosa, is recommended to be used every night at bedtime. It's 6.5 milligrams of DHEA in palm oil, so it's also moisturizing. My only problem with Intrarosa is that DHEA is super cheap, and we've been compounding with it at my pharmacy forever, and you can buy oral DHEA over the counter very economically, but Intrarosa is $330 for 28 inserts, and there's no generic yet. And it's not even approved for anything other than pain with intercourse. I've never filled a prescription for it for someone, so I don't know for sure, but I'd be surprised to see an insurance company pay for it. At least not without some kind of prior authorization, mother may I process. Since DHEA is over the counter, well, in the US, but not in Canada. In Canada, it's a tightly controlled, prescription-only controlled substance. It looks like there are a couple of over-the-counter DHEA things you can buy on Amazon: Julva Vaginal Cream and Bezwecken DHEA inserts. I have no idea if they're any good or they actually have any DHEA in them, or if they contain lead or grass clippings or what. The joys of the supplement world. But it's possible that they're good. Now, I know that I'm biased as a compounding pharmacist, but I really do believe that getting a prescription for a compounded product would be a great option here. There can be some sketchy fly-by-night compounding pharmacies, especially internet pharmacies, which is too bad because it's really sad to have your guard up trying to utilize what should be a trustworthy, honest, and highly regulated healthcare establishment. It makes me crazy because the pharmacies that I work at care a whole heck of a lot about providing the best possible products to their patients. If you had a good compounding pharmacy, a compounded vaginal product could be really great. A little estradiol, maybe even a little estriol, a different kind of younger woman's estrogen, a bit of testosterone, maybe some DHEA, and its special non-irritating cream or suppository base. I think it could be really great. And it would probably only cost around $40 or $50-ish, depending on how much you buy. Your insurance would almost certainly not pay for it, though. You'd also have to have a prescriber willing to explore some unconventional options, which isn't always as easy as it should be. Maybe we'll talk about the benefits of vaginal testosterone, or even systemic testosterone for midlife women some other time. To sum up, I think vaginal estrogen is a good thing. Vaginal DHEA is good, and vaginal estrogen and testosterone together, plus or minus DHEA, is great. I think almost every woman should eventually be on something that provides estrogen vaginally. Every woman is unique, so there might be someone somewhere who shouldn't take vaginal estrogen, but I'm not quite sure who. There's likely something I'm overlooking, but since tiny doses really don't get absorbed systemically, even hormone-positive breast cancer and other things that would give us pause in the realm of hormone replacement therapy doesn't apply. Some questions you might have are, when should I start vaginal estrogen? I would say it's up to you and your doctor, but if you're noticing vaginal dryness, it's probably time to start. If you're in your late 40s or older, it's probably time to start. What about if you take systemic hormone replacement therapy? You're getting estrogen, progesterone, and testosterone systemically throughout your whole body and bloodstream. I'm a fan of that. I have a Udemy course teaching the basics of bioidentical hormone replacement therapy if you're interested. Even with systemic treatment, though, there's a good chance that you might still need a bit of vaginal estrogen and or testosterone. An extra 10 micrograms of estradiol placed vaginally twice a week is not going to alter your estrogen levels, so there's no kind of risk of overdosing on estrogen if you already take it. And there's a good chance that the hormone replacement you're on isn't going to be enough to counteract the effects of decreased estrogen and testosterone presence in your bladder and genitourinary system. If you have other questions, always send me a message at healthcouragecollective@gmail.com and I will do my best to answer you. Thank you so much for being here today. I really care about you being able to give more to the world as you get older and wiser. And I think vaginal estrogen plus or minus testosterone and or DHEA is something that can help you to be stronger and more independent as your estrogen levels naturally decrease. It might seem like a small thing, but being more comfortable, reducing your risk of developing life-changing urinary incontinence while also avoiding life-threatening infections and the resilience-destroying consequences of having to take antibiotics is huge. And I don't think it's on most women's radar. But now it's on yours, which is fantastic. Next week, we're going to talk about the problem with trying to fix your problems. Until then, remember the importance of locally delivered estrogen to your genitourinary health, and don't be normal. Thank you so much for tuning into the Health Courage Collective podcast. I am truly honored that you have paid me the enormous compliment of your time and attention. I would be so grateful if you would share this podcast with someone you know and subscribe so you never miss an episode. This podcast is for entertainment and information purposes only. Statements and views on this podcast are not medical advice. This podcast, including Christina Hackett and producers, disclaim responsibility for any possible adverse events by use of information contained herein. If you think you have a medical problem, consult a licensed physician.